How interesting.
Great. So welcome to everybody. We are a little bit late this afternoon, and there have been a few little challenges. And unfortunately, my co-presenter Peter Young is not missing in action today. He unfortunately is not well. So we wish him all the best for his recovery, and hopefully he's going to be back pretty soon. We don't need to play the music anymore. Lauren, thank you. So yeah, I think we can just get started with the presentation quite soon. And just for all of you, just as a reminder, next week we have a presentation by Dr. Lo Pastorius, and he'll be talking about the role of progestins in women at risk for spontaneous preterm birth, the final word. And also want to thank Ashley for her participation and her ongoing commitment to the webinars, and she will be helped and assisted over the next few weeks by Karen Bird. And so thanks to Karen for joining the team and for helping us to get these webinars going. But without further ado, as Peter always said, from a beautiful sunny afternoon in Cape Town, we are now going to be switching across to Dr. Despina Demopoulos, who's currently in Joburg. And Dr. Despina Demopoulos is a pediatric intensivist and head of the pediatric ICU at the Witwatersrand Gordon Medical Center in Joburg. And so we're looking forward to her presentation this afternoon. And she'll be talking about challenges in managing infectious diseases during pregnancy and in neonate, a case study presentation. So thanks so much. Something that does worry us a lot when we manage women in pregnancy, and always on our minds. And yeah, so really looking forward to spending some time this afternoon discussing this important topic. So yeah, thanks. I can see you're already sharing your slides. We're sorry that your camera isn't working, but we've got a very nice photo of you, so that's fine. Thanks so much. And yeah, so Despina, you can fire away. Can you hear me?
Yes, I can. Thank you. Can you hear me?
Yes.
So thank you very much, and thank you for the invitation, and thank you for the introduction. It's always an honor to talk to colleagues, especially obstetricians and gynecologists. And once again, apologize. Zoom is doing something with my camera, but fortunately, I think it might be a good sign. I've been on call, and you might not be wanting to see what I look like. So you get to look at that photo, and more importantly, the screen and the pictures that are coming on. So
sorry to interrupt, but I hope you don't mind, but we try to keep this quite interactive, and we have people firing questions into the chat and the Q&A as we go along. So if you don't mind, I might just interrupt you as we go along.
I actually prefer that because I really don't want anybody falling asleep. I've tried to put in a few video clips so no one falls asleep, but I'm quite happy if you can interrupt me at any stage. So as a pediatrician and as an intensivist working in the ICU, preventable infections have been a really something I really feel strongly about. And sadly, I've actually seen children die from a lot of these infections that are quite preventable. So if there's any opportunity to make that better, I'm there, and I really, really hope we can take something out of this. So what I'm going to be doing today is just discussing one of my patients, Masters et al. Just going to go through what our goals are, what actually happens. I mean, you know what happens in pregnancy more than I do. What are the recommendations? What are the challenges we are facing, and conclusion? And really would love this to be interactive. So as a disclaimer, so obviously these views are my views and not those of Sanofi. But thank you for asking me to speak today. So this little boy that I admitted to the ICU was a month old, and he had a 10-day history of a cough. Initially, it was just a normal cough, and then it became paroxysmal. And the parents were worried about his apneas, thinking that it might have been normal at some stage. He was a term delivery. He actually had a cesarean, birth weight 3.2 kilograms. And after birth, he was actually really fine. And the first presentation was to us at a month of age. And during this presentation, As you will see as I speak, he actually required to go on to nasal CPAP and supplemental oxygen. So apneas in a baby and a cough in a baby in the first month of life is always worrying to any pediatrician. And obviously infection is top of the list. And this is obviously the quite early postpartum period. I'm just going to wait for this to... So this is not the actual child, obviously, but this is a video of a child that's just a little bit older, about 3 or 4 months. I'd like you just to have a listen to the cough and watch the sound.
Okay. Okay.
Yes. Are you able to hear?
I don't think it came through on my side. Maybe I'm just not hearing it, but I didn't hear the cough.
Is the video playing on your side?
Yes. Yes, it's coming through now.
No. Okay.
Sorry. So I'm not going to play the whole video, but what I actually wanted you to just see was just to see how the baby was struggling, how the cough. So not all the babies get this paroxysmal cough. Sometimes it's just a normal cough or it's just plain apnea. But you can see with this baby how she would cough, cough, cough. Then it would seem like she couldn't breathe. And then she would go blue. And eventually, especially if a child's a month old, that's going to totally exhaust them. And any ped that would actually look at this baby would really panic. And you could actually hear the alarms in the background that are starting to go. So this little boy, his temperature was just a low-grade temp. His respiratory rate was sitting at 48 breaths per minute. SATs 88 to 92. And why I'm showing you all of this is that some people say it's a neonate, so it's a 1-month-old baby. They wouldn't really worry about this or worry about this. In an older kid, you definitely would worry about all of these things. But in a neonate, these vital signs might be sort of borderline. But if you actually examined him, you would see he had some subcost and intercostal recession. The chest sounded totally clear, but he was having these apneas. And we did a nasopharyngeal aspirate that showed a Bordetella pertussis PCR positive. This was the X-ray, so really kind of non-specific, a little bit of hyperinflation that you can see over there, and a little bit of atelectasis, but it looks like a bronchiolitis, even though you can't really hear much on examination. So we put him on oxygen, we gave him some IV fluids, and it just got worse. In the next 24 hours, he needed more and more oxygen. He was given azithromycin. He was fed via the nasogastric tube. His initial blood gas wasn't too bad. So as I said, he went on to nasal CPAP. And a few hours later, he actually deteriorated significantly. Respiratory rate went above 60. He was quite pale and sweaty, and his pH had dropped to 7.17 and his CO2 to 72. And this is despite being on nasal CPAP, which means it's time to intubate. So he was intubated. He was put on positive pressure ventilation. These were his values on the ventilator. We managed to get good tidal volumes. We got a central line. He had an arterial line. And we added intravenous cefotaxime to his regime. So just to show you what actually happens with pertussis, and I know you do know this, but often we don't realize. So sometimes in the early stages, in stage 1, it's just a runny nose and maybe a little bit of a cough. And this is where the problem comes in, because you might have a sibling or an adult or a parent who's got just these symptoms and not all the other symptoms, and they might be infecting this little 1-month-old who hasn't been vaccinated. The next stage lasts for about 6 weeks, and this is the difficult part. So lots of rapid coughs, this whoop sign, vomiting and exhaustion after coughing. And the older you are, the more you can handle it, but when you're really young, you can't. And then there's the recovery stage, which is about 2 to 3 weeks. Coughing is less, the fits of coughing may return. So it's like the 100-day cough. This is the worst stage, and this is the stage where our children often die in the ICU, unfortunately. So the little boy developed ARDS, and this is what this is not his X-ray, but this is what the typical X-ray of ARDS with pertussis looks like. He was then put onto the oscillator. Oxygen index was 19, which is quite high, usually 40s when we ECMO. Just continued getting worse. We started nitric oxide, gave him steroids and surfactant. Unfortunately, then ECMO wasn't an option in that institution. And sadly, the little boy actually died with his mom and granny next to him. It came out with history that the mom actually had, most likely was the carrier, because she actually was symptomatic. So before we go on to the next part, maybe I can just ask and you know, thumbs up or some questions, some answers in the chat. How many of my colleagues on this webinar have actually seen a child with pertussis, or actually heard of some of their patients' children who have had pertussis, or their own patients have had pertussis? If you don't mind just giving me an indication, I'd just be interested.
No, I mean, we can, very happy for anyone to stick something into the chat and give us an idea as to anyone that has seen a patient with pertussis. I always thought it was a little bit something you see in the older child, so it's quite good to highlight the issue really in the younger child as well. Yeah, so maybe we can wait to maybe continue, and we normally just hear people you know, pop something into the chat as they go along. So
Perfect. So
maybe you can actually just give us, and then we can discuss a little bit later.
awesome. So the mortality and the greatest mortality that happens in these children is in the small babies, and those that are less than 3 months of age. So that's 80% of pertussis related deaths are in the small babies. And the mortality can go as high as 31% in a developed country. So this age group, this less than three months in a country that's not fully developed, is really very scary, as the mortality rate is quite high. If you actually do vaccinate during pregnancy, you can decrease the risk of pertussis infection by 90% in a newborn's first 2 months of life, and you can decrease pertussis-related deaths by 95% in infants of vaccinated mothers. And that was published in Crit Care 2011 already. So you might know that the UK, so when they realized there was quite a rise in terms of their mortality related to pertussis in the pediatric population, they instituted the UK maternal immunization program, pertussis maternal immunization program, 2014 to 2019. They noticed a significant reduction in neonatal pertussis during this period. The effectiveness of the vaccine was about 90%. And then recently, many other countries have adopted the same maternal immunization program. There is the one concern that comes through in some of the studies, and I actually recently was fortunate enough to attend the virtual ESPID conference, which is the European Society for Pediatric Infectious Diseases, where there was a whole session on maternal immunization, and some of the concerns that are coming out in first world countries is about the maternal antibodies blunting the newborn infant's response to routine pertussis vaccinations. But the studies are coming from the US, UK, Belgium, Vietnam. But the effect is not actually that apparent once children have actually had their boosters. So the clinical significance is still unknown, and a lot of people are still doing a lot of work, especially in Belgium, around this. And so actually just by giving boosters, if you're concerned when the child's a bit older, just by doing an extra booster seems to be okay. So just having a look at the global pertussis burden, the WHO 2015 did a bit of an estimate and looked globally, and I'll show you the graph on the next slide. And they estimated 56,700 pertussis deaths in children less than 5 years of age, and many of them among neonates. And more than half those deaths occurred in Africa. There are huge issues in terms of underdiagnosis and underreporting, because the problem is that not everybody actually tests for pertussis. So a lot of the times children that have died in many areas in Africa or South Africa and the neonates or in the neonatal period have died, we just put down respiratory distress. So they haven't actually been tested. And in the smaller babies, in the neonates, it's not as typical as in the older infants. So sometimes you might just have apneas, or you might just have a cough and some chest x-ray changes. So we definitely think that we are underreporting and underdiagnosing pertussis in the neonatal period. And then there's what contributes to the global pertussis burden is the waning immunity following childhood vaccination. So we basically, our kids get vaccinated at 6 weeks, and then they get their boosters and they're doing okay. And then once they sort of become adolescents and then adults, their immunity has waned, and then they can pick up the infections. And they don't get as severe as the children do, but they are the ones who end up spreading it to these little neonates or to these children that are unvaccinated. So this is the WHO estimates that I was talking about. And then you can see over here that we are quite high in Africa in terms of our under 5 pertussis deaths, and this is 2015. And there've obviously been a few surges after the COVID pandemic because of a lot of the anti-vaccination in some areas, but also a lot of our families didn't actually get to clinics to vaccinate their children. So this only goes up to 2015, but there are other studies. So over and over again, and I'll show you how many studies there've been, over and over again, large-scale immunization programs have actually shown a steep decline in pertussis incidence, but still in some areas where there's good vaccine coverage, we still have pertussis disease, and it's still quite endemic, including low middle income countries and those that have, as I said, good vaccine coverage. So even though we're giving it to our babies and our infants and our children, it's still not enough. And that's why WHO recommends in these countries that we need to implement pertussis maternal immunization. And the most efficient strategy that they are recommending is the 1 dose of the vaccine administered in the 2nd or 3rd trimester and at least 15 days before delivery.
There has been a question here about subsequent pregnancies. Is 1 dose enough?
Yes, so that's a very good it's a very good question, and that actually came up in ESPID, and 1 dose is not enough. So you need to. So what actually came up at ESPID is that we should be vaccinating our moms during each pregnancy. It would be wonderful if the pregnancies were 5 years apart, but they're not. What they are trying to do is just to not give the whole Tdap every pregnancy. So not to give the diphtheria and the tetanus and everything every pregnancy, but just to give an isolated pertussis boost in every pregnancy. So it is recommended to give it in every pregnancy, but there are some people in the world that are concerned that giving the whole vaccine every sort of 2-3 years is an issue. So what the general feeling from one of the panelists is that we should gauge our patients. So if the pregnancies are sort of 1 year apart, so exceptionally religious family that has 5 babies in 5 years, then you're not going to vaccinate every single year. But on average, if it's every 2-3 years, you should be vaccinating because the immunity wanes. And the mom's not going to have the immunity to give to the baby. So it's a very difficult one. I personally feel that we should be giving it in every pregnancy because every neonate can die. And I obviously have had it in all my pregnancies, but I understand why some people are hesitant giving the full vaccine every year to a family. Yes, but what the best thing would be is if we could actually test the pertussis antibodies in the mom and see that she actually had adequate antibodies to give to her neonates. So generally the feeling is to give them in every pregnancy. That there was a big discussion about that at the recent ESPID. Is that okay?
No, absolutely great answer. Thanks. There was just another question from Leonalia asking, have they started to use the mRNA technology into all pediatric vacs?
Not in all of them.
Okay.
Not in all of them. Not in all of them. But they are in parts of the world. They are not yet in South Africa. So what is our actual goal? And it's simple: prevent infection, prevent death. And with anything, if there is a solution, so if there is a vaccine, then it makes life so much easier. So this is just from the maternal immunization against pertussis, part of the Melinda and Bill Gates Foundation, where they looked a lot into, and they were quite involved in terms of pertussis maternal immunization across the world, and just looking at what would be the ideal continuum of care would be to obviously have the fantastic antenatal care that we could, but then there's this susceptibility zone, and this is the birth to 6 weeks, and this is where my patient passed away, and unfortunately he's not the only one that I've had, and it's this 4-5 week, just before 6 week mark, where they get pertussis, they haven't been vaccinated yet, and they have no antibodies from their moms. So this is the period where the babies die. And so ideally, if we could do something about this, and that would be the maternal immunization, and then the children can get their 6 week, 10 week, 14 week, and the EPI, and that should provide quite good immunization until they become adolescents, adults, and then they should get boosted again. Just as an aside, we actually have asked, so where I was working in that ICU, all our nurses, we vaccinated all our nurses. And the recommendation is every 5 years to healthcare workers that are seeing pertussis regularly, because we were seeing quite a bit of pertussis, and you pick it up and then you don't realize you've actually sick with it, and then you can pass it on. And so it's quite important to make sure your staff are also vaccinated. Okay, and this is the ideal continuum of care. So I'm not going to go too much into this because I'm sure everybody knows a lot of the history in terms of vaccination with women and pregnant women. But it's quite interesting to see how before, the recommendations came quite early in terms of maternal tetanus, 1930s, 1940s. At some stage, we were only looking at high maternal risks, giving vaccination to high maternal risks. And then with a lot of trials, we realized that we generally recommending it for all maternal immunization. And as I'll mention later, the recommendations are influenza, Tdap, COVID, and now Group B strep and RSV are on the rise. Just in terms of the outbreaks in the past, we've gone through a lot, and I think we need to be reminded that a lot of the outbreaks in the past have actually been managed with vaccines, and how we got rid of a lot of the stuff was with vaccinations. And if you actually look at the timeline, it's exceptionally interesting. Acellular pertussis started over here, and the current vaccines in development in the 2020s are sitting here. In terms of publications on vaccines in pregnancy, there's quite a bit. You can see right here, there's lots of publications and quite easy to find safety and lots of safety studies in terms of immunization during pregnancies, a recent review in Africa. So the evidence is there, And so we can't hide behind not having the evidence anymore. So we know that when we vaccinate our mums, the main protective mechanism of vaccination is the transplacental transfer of maternal antibodies. But there's a lot being said now in terms of priming the fetal beta cells and T cells. So it seems that it's not just maternal antibodies that are transferred across with the placenta, but there's actually a lot of other stuff happening to the fetus in terms of priming the fetus. And there's also a lot of investigation around the role of cytokines, and that's quite recent in Vaccines 2022. So what is the recommendation? So the CDC have their recommendations. Most countries have their own recommendations, but the general recommendation, and especially for South Africa, is the influenza vaccine, especially during season, pertussis vaccine, tetanus toxoid, and then recently COVID-19 recommendation came out from the Department of Health. And at-risk pregnancy, you can need to look at hepatitis B and meningococcal, and in development, RSV and Group B strep. Any comments around that?
Yeah. Can I just ask, so are we still vaccinating pregnant women against COVID then, or is it, I mean, hasn't that sort of declined quite substantially in the last few months?
Yeah, so it definitely has declined quite substantially, and the recommendation still sits there with the Department of Health. But I know that just by speaking to colleagues in the adult intensive care, because we all kind of share a lot of our information and have forums, they're not pushing for the COVID-19 in the pregnant women anymore, because the rates have definitely decreased. That I do, most likely if we hit another Delta wave or something more serious, then I'm sure this recommendation will come back. Sadly, when we were in the middle of the horrible pandemic, we still had, I know there was a drive to get a lot of women vaccinated, but we still had some of our colleagues who weren't recommending it. But yes, I agree. I think we're not pushing for this as much now, and we're not seeing COVID-19 in our babies like we did at that stage. There was a stage where we're seeing COVID-19 in our newborns quite a bit, and so vaccinating the moms really helped. But we're not seeing that. Not that we're not seeing any COVID, but we're more worried about all the other viruses much more than COVID. I'd rather be worried about RSV. And if I had to choose between an RSV vaccine and a COVID-19 vaccine for the mom, I would definitely choose the RSV. But yeah, I think that would be if there's another pandemic, if COVID's on the rise again. So, I mean, South Africa has got its own, but the general recommendation is 27 to 36 weeks with tetanus, diphtheria, and pertussis. And I'd be interested to know if that is what we are doing. This is the American Society of Obstetricians and Gynecologists. So their summary is those that are indicated every pregnancy. There's the ones that can give it in certain populations, contraindicated. Obviously, the live ones are contraindicated and can be initiated postpartum or when breastfeeding or both. So what are the actual challenges? So vaccine acceptance is a big thing. And I think we really realized that during COVID. The concern whether or not we actually need the vaccine, whether or not the vaccine side effects are worse than the benefits, and trying to get our patients to accept the vaccine, and sometimes even our own colleagues to accept the vaccine, is a really difficult thing. What was mentioned recently at the conference was those that are doing the studies on the RSV vaccine, they found that the uptake with the patients, with the mums, was much better with the RSV vaccine versus COVID. Now, we know that pregnant women were left out of the initial trials with COVID, sadly, but with subsequent trials, so the families and the moms are much more open to getting the RSV vaccine versus the COVID vaccine, which is quite interesting. And they think some of it is because RSV, everybody knows that if a small baby gets RSV, they will die. And so moms would say they would do this for their kids and not thinking that they would die from COVID. but also probably a lot of the media hype that's gone around the COVID vaccine. But definitely the uptake in terms of vaccine acceptance is different between the different vaccines. So we need to figure out our challenges, or how are we going to change vaccine acceptance. And I think working with each other, so working with colleagues, obstetricians and pediatricians is quite important, especially neonatologists and intensivists that see these children working in the same hospital, and encouraging each other. And then we definitely need to improve our surveillance in South Africa so that we can actually show our families what our infection rates are, because definitely we are having many more pertussis deaths than we are actually recording. And so we need to improve the surveillance throughout the country. So vaccine acceptance, I put this slide just for the right side. How do we actually go about doing it? So promoting public engagement, vaccine awareness, adequate information and teaching. So probably always starts at medical school, I would think. Trying to get rid of the misconceptions around the risks. I don't know if we'll ever get rid of those, but I think we can try. Partnerships between the maternal cohorts, healthcare providers, local communities, the broader public. And then we need to go and have a look at what's happening with our compliance in our areas and how we can improve it. I know as pediatricians, I sit on I'm the vice president of the South African Pediatric Association. I know from the Pediatric Association, we struggle obviously with vaccine acceptance in some of our parents and in certain areas. And sometimes just taking it on with the anti-vaxxers is very, very difficult, despite us having all the evidence. And we've reached a stage where some of our colleagues, especially in private practice, are refusing to see certain patients if they haven't vaccinated their children. So it'll always be, I think the anti-vax movement will always be a difficult one. But I think with maternal immunization, we can do a lot, because a mom just wants the best for her child. And if she knows that she can save her child from dying, and sadly, that little boy, his mom did ask me if she was vaccinated, if he might have not died. And it's very hard to say, and I'll say it's very hard to say, but vaccines can prevent deaths, and she never knew that there was that option, that she could vaccinate for pertussis in pregnancy. We need to also make sure our vaccines are safe, and in the States especially, and we have that here, if there's any problem that we pick up, we need to report it. And then we need to make sure we can get our vaccines out there. So we need to make sure that wherever the pregnant women are, the vaccines are available, and that the whole chain is actually flowing. So good surveillance, looking at good morbidity and mortality outcomes, and then presenting. So if there is one life-saving solution that the world has yet to fully unleash, it's definitely maternal immunization. And I think it's a whole other area that we haven't really actually unleashed, and we can actually prevent a lot of deaths. So to conclude, and I know it's a little bit early, and we've got 20 minutes to go, but I'd like to rather discuss a bit more and find out what everybody's doing, and if there's any way that we could collaborate in terms of pediatrics and obstetrics to make this better. So maternal vaccination is a public health measure that will be able to protect transmissible diseases, reduce maternal death, prevent neonatal deaths, and the ones that are actually recommended is pertussis, tetanus, influenza, and RSV will be out everywhere very soon, and then streptococcal. Thank you. And
thanks so much. Yeah, thanks so much, Despina. That was amazing, and I think you really just highlighted such an important issue, and I don't really have a very good feeling myself as to how many of my colleagues are actually discussing this, with their patients. But what is your general feeling about just the uptake and how many women are
Yeah.
actually offered this in pregnancy. Do you have any data on this at all?
Yeah, so we don't actually have in terms of South Africa in terms of, and we are really not great in terms of pertussis. So we are great in terms of tetanus, and that's because it's out there in the clinics. So it's part of, it's on the antenatal cards in terms of the state clinics. And so they have to have their tetanus, and we've got those stats. So we've definitely got the stats that show neonatal tetanus has declined tremendously. But the rates of women being vaccinated, maternal immunization with pertussis, I haven't been able to find that. I don't know if anyone else has. But they do have, they've got great stuff in terms of overseas. So Belgium, they're doing great stuff. The States very much in Europe. Then I can tell you that just asking around, majority, and obviously now this is sort of private medical aid, parents have not been vaccinated in their pregnancy. So sadly, I think that if they haven't, I'm not too sure if it's everywhere else, and that's what I would like to find out from our colleagues. But from just looking at our, going onto our NICD and our looking at all our stuff that I could find, not much. So what has happened is the Prof. Shabir Mahdi and team have looked a lot at the streptococcal, obviously, and they've looked at the vaccines there, and also been part of the Melinda and Gates, and Bill Gates, but specific pertussis numbers of women being vaccinated I couldn't find. What is your general, are we out there talking?
Yeah, I don't think it's being offered very widely in Cape Town. I'm not sure I could speak to more of my colleagues, but yeah, I think the awareness, especially of pertussis, is quite low. That is my feeling. But it may be a very good time to bring on, and we want to thank our sponsor Sanofi for helping us tonight to put this webinar on. And we do have Ayanda Luxoma on, who's the customer success manager for EM Guidance, and maybe it's not a bad time to just maybe get a comment, from the industry, because maybe you've got a better understanding of what might be happening in the uptake. Did you maybe want to make a comment right now on that point? Ayanda, are you there?
I'm here, Prof. How are you?
Fine, thanks. Yes. So yeah, we thought maybe it's a good time to bring you on this. What have you seen in terms of the uptake of the vaccine, and how the vaccine's actually moving in the different parts of South Africa?
So the most interesting thing is, because we are a digital platform, EM Guidance is a digital platform, we have various data insights as to that. So we get to see that a lot of the HCPs that are part of our community, they get to access that information on a monthly basis. We get to note the amount of views, the amount of clicks, and the amount of engagement that we have as a medical information platform. So we're definitely seeing the interest, and hence Fatima and the Sanofi team said it's quite imperative that we come on board and we attend this meeting and showcase what it is that we offer as to the medical community, so that more and more HCPs are aware of how to access this sort of information going forward. Okay.
Yeah. So so do you have any data on the uptake of specifically the pertussis vaccine?
We do. A colleague of mine is online. I don't have it readily available with me today. I wasn't sure that we were going to require to show that, but we do have it. It is available.
Okay. All right.
Yeah.
Great. Well, we do have two other questions while we maybe wait for that to become available. But Leon now has come up again saying that they haven't seen a single COVID death in babies, so RSV would be a more important vaccination. You got any comments about that, Despina?
Yeah, so I totally agree. I would choose RSV over COVID any day. Vaccination, I'm saying. Yeah, I think I wouldn't. If I was an obstetrician, I would never hesitate to give a mom an RSV vaccination, because the amount of children we've lost in ICU or who land up in ICU and sick for a long time are definitely from RSV. Strangely, with COVID, RSV season it's all over. It's not as defined as it used to be. And the other thing is that, trying to, so some of our at-risk patients, so patients that are immune compromised or at risk of other things, trying to get the synergists to be paid for by the medical aids is also quite difficult. So if we can prevent anything, I think RSV would be a good one. So hopefully, at the Congress, they were saying that in the next they were thinking 12 months to 18 months, the RSV vaccine should be out in developing countries, but I don't know, we'll see.
Well, so an anonymous attendee's got a question asking, what are the concerns regarding giving mums the DTaP repeatedly? And do we indeed have an isolated pertussis vaccine in South Africa?
So Ayanda, do you want to answer the part about the pertussis vaccine? Or are you happy that
I'm happy, Doctor, for you to proceed.
Perfect. Okay, so we do, so the concerns of giving repeated DTaP is when we're talking about, so it's just about giving, well, really, not sure though, in terms of the tetanus and the diphtheria regularly. So as I was saying before, the general recommendation, even with occupational health, is every 5 years, that you don't actually need to get it before that. But the concern is giving the whole DTaP, so giving the diphtheria and the tetanus every year. I think there's a worry about just actually giving, and I'm not too sure if it's related to any side effects on the mom. I know for the babies, we really don't. I mean, we don't see diphtheria in their neonatal period at all. It's just tetanus that we actually see. So I'm sorry, I can't actually tell you exactly why the diphtheria and the tetanus are a problem to give every year. But I know that at the conference, they were really emphasizing that it should just be an isolated pertussis vaccine in every pregnancy.
Okay. And then Fidelis Abidike has asked what are the current national guidelines here in South Africa regarding these additional vaccines?
Yes. So currently in South Africa, the only ones that they're getting in public hospitals is tetanus, as I was saying, and in the clinics. So that's on the antenatal card. So it's still only tetanus. So like all things in the country, we have to try and fight it and convince the the VMAC. They did, from what I understand, during COVID, and you maybe can help me, recommend the COVID vaccine from this in the government clinics during the COVID hectic pandemic, but not the others. So the others are definitely not in the government recommendation. It's not in the national guidelines at all. But that can change. It really can. So pediatrics, we never had the rotavirus and we never had strep pneumococcal until years ago. And unfortunately, I was busy specializing before we had those vaccines, and it was absolutely horrible. And then finally, we got those on the government national guidelines and on the EPI, and it made such a huge difference in terms of the patients that we admitted. So hopefully we can actually change that if possible.
Oh. Usain Ackman wants to know if we require informed consent from pregnant patients in case of an adverse reaction. Would you do a written, well, I mean, for these vaccines, I mean, would you do a written informed consent, or is the sort of tacit agreement to go for a vaccine and to actually stand and take the vaccine good enough? I'm not sure if anyone is actually getting a written informed consent.
No,
but
I don't think anyone's getting a written informed consent. I must say, I do realize generally in medicine that everyone's trying to get more consents than they used to get before. I mean, recently we've been asked as pediatricians to get informed consent for Perfalgan, IV paracetamol, because it's off-label in children. But I mean, with us, all the drugs are off-label, so it's quite difficult. So I don't know of anybody actually getting informed consent, and I don't think that that's happening in the clinics. I think it's more like you have to have this and that's it, you know.
Yeah.
There's another one there.
Yeah, there's another question. Tdap
Oh,
is seen in
that's
pregnancy.
okay.
Yeah. Sorry.
Sorry, I just see it is in the South African Society of Obstetricians Gynecologists recommendations, but
Okay.
not national guidelines though. Am I correct, Dr. Blanche?
Okay, we can wait for that answer.
Sorry, there was also the concern of blunting. I did mention in one of my slides that if you do, it can affect immunizations later on if you keep vaccinating. But what's been shown is that if you just boost the children later on, they're actually okay. So it doesn't seem to be a clinically significant concern at the moment.
And then just the important question about medical aid coverage. Is it covered on a lot of the plans, or is it mainly out of pocket for the pregnant patients? Pertussis in particular.
That I actually don't really know, to be honest.
Okay.
I know with our pediatric, maybe you can help with that, Ayanda, but I do know with our pediatric vaccines, they actually they can claim back. So they pay and then they claim back. But I don't know if you can, I'm not too sure with the medical aids in terms of the maternal immunization. Ayanda, do you know?
No, I don't, Dr. Despina. I am not in the reimbursement space at all. I don't know whether Fatima would like to take that answer.
Ashley and Karen can unmute Fatima. That would be great. Maybe she can just, if she's happy to just speak, to that subject.
I know she is traveling. She might have communication problems, so let's see if she comes online.
Okay, but maybe it would be good to have another.
Hi, Dr. Jeffrey.
Yes, hi. Yes.
Hi, sorry, I'm just, I did inform Ashley we're just traveling at the moment. So just to address some of the questions, I think the latest was in terms of reimbursement. So the vaccine is reimbursed currently privately. Depending on your plan, it's either, or on the patient's plan, I should say, it's either part of their maternity benefit or their savings benefit, but it really varies plan to plan. And if there are any specific reimbursement questions or concerns that somebody's heading trying to claim for it, you're welcome to contact the Sanofi team and get our details from Ashley, but it is currently reimbursed. And then in terms of the public sector, as Dr. Despina has stated, the vaccine is not currently available in the public sector. However, there has been a need identified by EPI and by the Ministry of Health. And so actually the plan is to introduce the Tdap vaccine in the public sector in 2024. So that would be next year. So there are plans to actually introduce that together with some other pediatric vaccines next year. So hopefully, we should be seeing that as well.
That's absolutely awesome. I'm so glad to hear that, Fatima. And no isolated pertussis vaccine at the moment.
Yes, so all currently pertussis available vaccines, be that for pediatric or for adults or for wound care, they're all, not for wound care, sorry, but for adults and for children, all pertussis containing vaccines are currently available as a combination vaccine. And this has been more for, I would say, like boosting purposes. So for example, that's why in pediatrics, you have a hexavalent vaccine, which was really amazing when it just got launched, because now you don't have to give a whole lot of 6 singular vaccines. You give one vaccine and essentially protecting against 6 diseases. And so currently it's the same with the Tdap vaccine.
Yeah. So there isn't an isolated one in South Africa.
Yes, that's correct.
Great.
Awesome.
Well, good. Well, looks like
Jeffrey, you had one more question, I think, in terms of what has been the pertussis uptake.
Yes. You do. I know that we don't have any hard data. I don't know you might have, but what is the general feeling? Is it something that is being done? How much work still needs to be done in this space?
Well, I think right now to get concrete numbers, as Dr. Despina herself stated, right now it's only available in the private sector, and we've seen, I would say, varying uptake in in the different provinces. So I feel like we've seen that some uptake in some provinces are better, and in other provinces it's a little bit lower. We have seen though an improvement since the time that the vaccine has been launched, and hopefully then if you're looking for that concrete data when the vaccine is launched in the public sector next year, we'd be able to get some more concrete numbers. But because it's not yet available nationally, it's also a bit more difficult to kind of monitor the usage.
I think, Fatima, I think you're right, like the tetanus. So once it gets into the private government sector, we'll be able to get more data, I think.
Yeah.
But if you can prevent one neonatal pertussis death, then please can you do it? Because the worst thing in the world is watching a child die from something preventable. And sadly, I've seen that with measles, seen it with pertussis, congenital rubella. It's actually horrible. So yeah, but pertussis is I mean, I've mentioned to one or two of my intensivist colleagues saying, I'm going to be giving this talk. I didn't say what, I just said maternal immunizations. And I said, please speak about pertussis, you know, so I think it's really a tough one.
No, thanks. I mean, I think it's been a very important topic tonight, and you know, I'm sure you've highlighted to many of the people on tonight. So thanks so much.
Thank you.
Yeah, I mean, I think we're really coming to the end now. It's really been a fantastic talk, and I think it will hopefully make a difference to our patients and to newborns somehow. Yeah, I don't think there are any more questions. And Ayanda, thanks so much for your input. Was there anything more you wanted to say?
Yes, Prof. Jeffrey, I actually wanted to just showcase the platform a little bit, because I feel as if we've got a wealth of information that the HCPs online can actually appreciate. There's a lot of value in utilizing the EM guidance platform, and I wanted to just show it, and then even if it's just for 2 minutes, and show how they can navigate their way around it. We do have a lot of information on pertussis, as well as the various drugs there. We can showcase how doctors can actually utilize that at the point of care. And it's a free platform as well.
Okay. Great.
Okay, thank you. So I'm sharing my screen. So basically, I just want to start off and just say, who is EM Guidance? EM Guidance is a South African prodigy. It was founded by 2 South African doctors, Dr. Yasin Khan and Dr. Mohammed Dilwali. And we actually exist to empower the front line of healthcare delivery. This is a free platform. We offer independent, localized information in collaboration with the healthcare ecosystem and the medical industry. So these are all our partners in the ecosystem at this point in time. So we rely on this ecosystem to actually make sure that the information that we have is clinically relevant. Right now, as it is, we've got over 57,000 HCPs registered on the platform. The platform is available as a digital tool, either on a cell phone, an iPad, or on a laptop or a desktop. So we have over 27,000 doctors with over 1.5 million sessions per month and over 12,000 daily active users. And again, I want to just emphasize the fact that we are the largest free and engaged online platform for healthcare workers in South Africa. So we exist through awareness, through education, practice support, ensuring that we minimize clinical errors, ensuring that doctors are aware of whatever is pertinent within the healthcare ecosystem at the time that the information is available. So we are there at the point of care. So I'm just going to showcase the platform quickly. So if you go there, so once you have registered, because this is a closed ecosystem, all doctors have to register. We then verify that information with the HPCSA. You have to be an active member. Then you have full access to the platform. As one lands on the platform, you get to see the latest updates, which is the latest news articles. So this is what we're talking about when we're referring to awareness. So you can also search for guidelines. Like this evening, we've been talking about pertussis. So if you check there and you just look up pertussis vaccines. You can see everything there is to know that we currently house on the platform with regards to that. You can see there's Adacel Quadra, which is a Sanofi product. This is something we call the product listing. So we will get this information from Sanofi or get the information pertaining to this brand from SAPRA. So if we go back to the first page and then we look up, for instance, I just want to go and say, let's say the guidelines. Let me just go HIV, for instance. You will see that whatever guidelines you were looking for, those will come up at the bottom. So also in terms of pertussis, there will be HIV guidelines in pertussis. So again, in terms of drug-to-drug interactions, we've got something called an interaction checker, where a doctor, for instance, the case that we were looking at right now was a patient which was given erythromycin. Assuming that the patient also got fluconazole, you can quickly check that. And then let's say if the patient was given aspirin, the system then works out the drug interactions between the various drugs the patient is on. So you can see that it will tell you that there is a severe interaction between fluconazole and aspirin and why you should avoid it. And then azithromycin and fluconazole and so forth. Another module that we have is actually the Learn module, where you can earn actually CPD points free of charge. Again, if you go to our Learn modules, these are available on demand for a whole year. For instance, the vaccination simplified, we've got a whole video clip there. You can earn CPD points, you can watch it at leisure if you don't have time. We also have understanding the basis of vaccination in pregnancy. So we've got various things, and this is where we draw our data. Let's say if you're saying we want to know what is the interest, is there enough awareness in terms of this disease entity? We can pull out data on the platform in terms of the number of searches with the various vaccines, the number of searches on the guidelines that doctors actually access on the platform, as well as the various learning modules that they would be interacting with. Also, most recently, we've added calculators. We've got over 800 calculators here, and then doctors can also access that at no cost at all. So this is the platform in a nutshell. Also, in terms of doctors that are actually treating diabetes, we've got a lot of diabetes agents on the platform where doctors can actually complete a JOT form or an intelligent form and actually submit the form through to the medical aid, depending on the patient uniqueness. So we assist with motivations as well. So I don't know whether there's any questions, but I was just requested to showcase this platform and the fact that a lot of HCPs across South Africa, over 57,000 HCPs, are actually engaging with our information. And the reason behind it is that this is an unbiased platform. It's verified information by doctors for the HCP community at large.
Well, thanks very much for showing us that. And it does certainly look like a very useful platform for us to go and look at. But I think we have come to the end of our time, and we do want to thank Sanofi again for the sponsorship of tonight's session, and also a very big thank you to Despina for taking time to talk to us tonight as well. And we do look forward to more engagement and discussion on this very important issue of vaccine in pregnancy, which certainly makes a big difference to our patients and to the neonates as well, obviously. So we thank so much. And yeah, that comes to an end. We again wish Dr. Peter de Jong a speedy recovery, and hopefully we'll be seeing him back on the webinar next week if he is well enough, when we'll be having Loba stories looking at the role of progesterone in women at risk for spontaneous preterm birth. And he's going to give us the final word on that. But thanks to everybody. And as Peter always says, safe home. And thanks very much for joining us tonight, and keep warm. Thanks so much.
Thank you.
Thank you. Good night.
She's so pretty.